Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering part 2 of diabetes. As I explained in part 1, diabetes is very, very heavy. So there's no way that I was able to make this video in one session. It's not even going to be possible in 2. So this is probably going to be 3 or even a 4-part series. So in this session, guys, I'm going to be covering the difference in the clinical manifestations of diabetes, the diagnostic tests, and I'm going to get into the treatments. I'm not going to finish them all. That's going to be this is part 2. So that's going to be part 3, but I'll definitely get into part of the treatments for diabetes. If you haven't done so already, guys, you know you're going to like this video. Go ahead, like this video, subscribe to my channel, and press that red notification button so you'll be notified every time a new video is released. Don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com. And if you want to practice more questions during the week, you can always catch me on TikTok, Instagram, and Facebook. Every Sunday, 1 p.m. Eastern Standard Time, I have a new video released on YouTube that covers questions. Okay, guys, so without any further ado, let's get started. So let's take a look at this with the clinical manifestations. Let's start here. Where's my mouse? There we go. Right here where it says type 1 diabetes mellitus. So look what it says. It says, because the onset of type 1 diabetes is rapid. If you watch my video in part 1, how many times did they tell us that the type 1 diabetes, the onset's rapid, it's acute, versus your type 2, where it's slow, it's insidious, it's chronic, it's sneaky, right? There's a reason that they keep repeating the information to you, because you're going to see it on a test somewhere. You need to know the differences. So when it comes to your type 1 diabetics, the onset's what? Rapid. It's rapid. The classic symptoms, again, your 3 Ps, your polyuria, polyphagia, polydipsia. Polyuria, polyphagia, polydipsia. Right here in part 1, I explained why. Okay, so let's keep going. Weight loss, it can occur because the body cannot get glucose, look at this, guys, and turns to other energy sources such as fat and protein. So in your type 1 diabetics, you may see that patient thin, and the reason why, remember, all of that sugar is stuck in the blood, but it's supposed to be where? In the tissues needed to survive. So what happens is your body's trying to survive no matter what. So when your tissues are like, whoa, you know, we need this glucose for energy, we need this glucose to survive, but we're not getting any, it's stuck in the blood. What are we going to do? Right here, guys, it's going to start feeding off of your own fat and your own protein, because it's being starved of the glucose that it needs, because the glucose is stuck in the bloodstream. Okay. Remember, I told you type 1 is more prone to have what? Ketoacidosis. Look at this. Ketoacidosis, it is a complication most common with those in type 1 diabetes. It's associated with clinical manifestations, and we're going to talk about that later, but that's very important for you guys to know. Type 1s tend to have ketoacidosis, also known as DKA, and your type 2 tends to have your HHNKS, which is your, someone told me, reminded me in the comments, because I couldn't remember what it stood for, but it's that hyperglycemic, hyperosmolar, non-ketone. Okay, so there's a difference. Your type 1, DKA, definitely ketones. Type 2, HANKS, no ketones, and we'll talk about that later. So let's move on to type 2. Non-specific, gradual, insidious, but also the 3 Ps, your polyuria, polydipsia, polyphagia. Your polyuria, you have excessive urination. Why? Your body's trying to get rid of all that sugar. Polydipsia, that's your excessive thirst, trying to dilute all that sugar. And then polyphagia, excessive hunger, your body's trying to survive, and it's not getting the glucose because the glucose is stuck in the bloodstream. So you have the excessive hunger, trying to eat more food to get to the glucose, but to get the body the glucose, but unfortunately that glucose is stuck where? In the blood. So these 3 you have to know for your type 1 and your type 2. What else do we see? Common manifestations: fatigue, Recurrent infections. Remember, I told you bacteria loves dark, moist, sugary environments. Patient got diabetes. Don't you think they're full of sugar? Yes. Recurrent vaginal yeast or fungal infections, prolonged wound healing, and visual changes. And I'll explain all of those in a little bit. But you see all of these guys, these are select all that applies on NCLEX. You better know them. Don't say I didn't warn you. Let's talk about diagnostic tests. I know by now you're like, Professor D, you're getting on my nerves. I have to know everything. Yeah, when it comes to diabetes, you do, because so many Americans suffer from this disease. You're going to see this so much when you're on the floor working. And so the Board of Nursing needs to make sure that you know this, you know what to do for your patients. So let's look. The diagnosis of diabetes mellitus is made using one of the following methods. So they give you 4 methods, but guess what? We only need one of them for that patient to be diagnosed as diabetic. What are they? 1, having a hemoglobin A1C of 6.5 or higher. What did I write here? I said, if 1 is positive, the patient had diabetes, 90 days prior. So let me explain that to you. The hemoglobin A1C, that gives you a clinical picture of what that patient's blood sugars look like for the past 90 days, for the past 3 months. And the reason this hemoglobin A1C is important, when the patient knows they're going to come to the office, you know, the night before, the day before, they'll only drink water all day. They'll only eat salad so their numbers can look good, right? But when it comes to that hemoglobin A1C, you can't fool the healthcare provider, because it gives us a picture of what your blood sugar has looked like on average for the past 3 months, 90 days. So that really shows us, it starts with a C, and this is what you get a lot of tests when they're asking you about hemoglobin A1C. This is what the test writers are trying to pull from you. They're testing hemoglobin A1C, shows you what? It starts with a C. What's that word? Compliance. How compliant has that patient been with their diet and exercise? Okay. What else too? Fasting plasma glucose level greater than or equal to, look at this, 126. 3, 2-hour plasma glucose level greater than or equal to 200. Or 4, in a patient with the classic symptoms of hyperglycemia, remember what those classic symptoms are: your polyuria, polyphagia, polydipsia. In those patients with those classic symptoms or hyperglycemic crisis, any random plasma glucose greater than or equal to 200. One of those out of those 4, that patient's diabetic. Now, a couple things I want to bring to your attention. What I have for 1, 2, 3, what did I write here on the side? Needs repeat testing. So if 1, 2, or 3 is done, we're going to repeat to confirm, okay? Choice number 4, what did I write here? Oh, all of them. All of them need repeat testing. You want to make sure. However, if one of them is positive out of that 4, they are diabetic. They get that diagnosis. All right, let's keep moving on. So I stopped here when I talked about them having the symptoms, and then we did a random glucose is 200, excuse me, if it's 200 or more, repeat testing is not warranted. But look why it's not warranted, guys, with those classic symptoms, okay? Otherwise, criteria 1 through 3 should be confirmed by repeat testing to rule out lab error. I want to make sure you guys catch this before I move on. So with 1 through 3, we want to make sure it's not any mistake we did on our side. We're going to repeat. If 1, 2, or 3 is actually positive, that patient's diabetic, right? But what they're saying with choice 4, we don't have to do a repeat. Why do you think with choice 4, we would not have to repeat like we would have to with 1, 2, or 3? It says right here that patients already exhibiting the classic signs and symptoms of hyperglycemia, your polyuria, polyphagia, polydipsia, or they're in hyperglycemic what? Crisis, which is a medical emergency. That patient's in hyperglycemic crisis. We're going to have them in the hospital somewhere. There's no need for repeat testing. We know this is what they have. It makes sense, guys. All right, let's move on. Excuse me. So the accuracy of lab results depends on the adequate patient preparation and attention to many factors that can influence results. For example, What can influence results? This is what we're talking about. Factors that can falsely elevate values include, you guys need to know this, recent severe restrictions of dietary carbs, acute illness, medications, restricted activity, impaired GI absorption, or one who's recently taking acetaminophen can cause false negative results. You need to know this whole list of what can cause the patient to have a false negative result. Hemoglobin A1C provides measurement of blood glucose levels over the previous 2 to 3 months, 90 days, guys, with increases in the A1C reflecting elevated blood glucose levels. The A1C has several advantages over the fasting plasma glucose, including greater convenience, since fasting is not required. They can't trick us. They can't fast the day before and trick us. Fasting is not required. Remember, it gives us a picture of what their blood sugars look like for the past 90 days. Diseases affecting the red blood cells, such as iron deficiency anemia or sickle cell, can influence the A1C, and it should be considered when interpreting the results. So the lab, when they're interpreting the results and you get those results back, you should consider this if that patient does have a history of iron deficiency anemia or sickle cell, because that can mess with the numbers of the hemoglobin A1C. You're going to teach patients with diabetes and pre-diabetes to have their hemoglobin A1C monitored regularly to determine the success of the current treatment plan. Let's stop right there. The success of the current treatment plan. So we told you diet, we told you exercise, we told you to take this oral hypoglycemic medication, we told you to take this insulin. That hemoglobin A1C is going to tell us whatever we told that patient to do, is it working? Are they being compliant? Okay. So it tells us the success of the treatment plan and make changes in the plan if the glycemic goals are not achieved. So we came up with a plan. Remember ADPI, you come up with a plan, you do your intervention. Now comes time for evaluation, where we're looking at the hemoglobin A1C. We're evaluating our teaching and what we told the patient to do, and we see that hemoglobin A1C is not going down. You're back to A in ADPI. Assessment, ask the patient questions. Hey, have you been dieting? Have you been exercising? Have you been taking your medication? You have to reassess that plan and then come up with a new plan. The ADA, that's American Diabetic Association. The ADA identifies an A1C goal for patients with diabetes, what? Less than 7. You guys see that? So you have to know the difference. If the patient does not have diabetes, they are not a diabetic, we expect that hemoglobin A1C to be less than 6.5. If they're a diabetic, we expect that hemoglobin A1C to be less than what? 7. Professor D, do I need to know this? Absolutely. You will see it as a test question. Let me make this bigger for you. All right, patient teaching. So you're going to teach them nutritional therapy, eat more vegetables, foods high in fiber, drink water instead of juice, drug therapy, take your meds as ordered, exercise, don't be a couch potato, self-monitoring of blood glucose, that's self-explanatory, are the tools used in the management of diabetes. And there's a table, we're going to go over that in a second. All individuals with type 1 diabetes require insulin. How many times have we seen this? Those that watched part 1 already, they drilled this into your head, didn't they? Don't you think that's going to be a test question? If a patient is a type 1 diabetic, they are going to be insulin dependent. You better believe it. They will not live long without insulin. They need an XEX, exogenous source of insulin, in order to survive. For some people with type 2 diabetes, a healthy eating plan, a regular physical activity, and maintenance of healthy body weight are enough to obtain optimal blood glucose levels. So with our type 1s, where they absolutely need insulin to survive because their body doesn't make enough, with our type 2s, many of them, diet and exercise is enough, or diet, exercise, and oral hypoglycemics is enough. They're not dependent on diabetes like on diabetes. They're not dependent on insulin like the type 1 diabetics are, okay? Where were we? Okay. However, eventually most people with type 2 diabetes will require medication management because diabetes is a progressive disease. That word progressive means as time goes on, it only gets worse. So when the patient's first diagnosed as a diabetic, you know, we may be able to control that blood sugar just with diet, exercise, hypoglycemia, or diet, exercise. Then as time goes on, we might have to add a hypoglycemic medication. And then as time goes on, unfortunately, the patient might have to be on insulin, all right? What did I write here? If they don't diet, exercise appropriately, yeah, they're gonna have to move on to oral hypoglycemics and then insulin. So let's talk about insulin. People with type 1 diabetes require, there's that word again, guys, exogenous. That means outside source. If you are type 1 diabetic, you absolutely have to have an outside source, an exogenous source of insulin to survive. And they often use multiple daily injections of insulin, often 4 or more, or continuous insulin infusions via an insulin pump to adequately manage blood glucose levels. Why? Because in part 1, you learned that naturally your body's releasing insulin all day. All day, it's releasing insulin in tiny increments, except when you eat a meal, then it'll shoot out a bolus because obviously when you're eating a meal, your blood sugar is going to go up. So think about that patient that's a type 1 diabetic, which means they're absolutely insulin dependent. Of course, they're going to have to take injections several times a day. Why? Because their body needs to mimic naturally what it should have done, okay? Let's jump over here to types of insulin. Today, people use only genetically engineered human insulin made in laboratories. In the past, insulin was extracted from beef and pork pancreases. Remember, the beta cells in the islets of Langerhans, and what? The pancreas is where insulin is made. But these forms of insulin are no longer available. Why? We can make it in a lab now. Insulin regimens. The insulin regimen that most closely mimics endogenous, remember that word endogenous, that means from within, your body's making it. So the insulin regimen that most closely mimics endogenous insulin production is the basal bolus regimen, which uses rapid or short-acting bolus insulin before meals and intermediate or long-acting, that's your basal, background insulin once or twice a day. Now this basal one, that's the one slowly releasing in the background, just like normally your body would, right? And this one, that rapid and short acting, that bolus, just like your body naturally a shoot out a bolus when you eat a meal, that's what it's expected to mimic, okay? The goal is to achieve a glucose level of 80 to 130 before meals. And we're talking about our diabetic patients. Remember, our non-diabetic patients, fasting blood glucose is supposed to be what? 70 to 110. But our patients who are diabetic, our goal is 80 to 130 before meals. Why? We expect them, because they're diabetic, it's going to be slightly increased. That's why if you're not a diabetic, you expect that hemoglobin A1C to be less than 6.5. But if you are diabetic, you want the hemoglobin A1C to be less than 7. Okay? Mealtime insulin bolus. To manage postprandial, what does that word postprandial mean? After eating. To manage postprandial blood glucose levels, the timing of rapid and short-acting insulin in relation to meals is crucial, is critical, is muy importante, very important, okay? Rapid-acting synthetic insulin analogs, which include Lispro, that's your Humalog, Aspar, your Novolog, and glucosamine, your Apidra, have an onset of action of approximately 15 minutes. And it should be injected within 15 minutes of mealtime. Let me tell you guys something, and this is where you guys get it wrong. It's not enough to memorize the onset, the duration, the peak of an insulin. You have to understand what it means, because the test question that you get is not going to be as easy saying, oh, when is the peak of this insulin, or when's the onset of this insulin? It's critical thinking. So they're going to tell you that the patient got, I'll use this as an example, that the patient got a rapid acting insulin at 8 o'clock in the morning. What is going to be a priority nursing intervention? You need to understand that the onset of an insulin, what that really tells you is when that patient needs to eat, by what time you need to have food in their body. Because what kills a patient faster? Hypoglycemia, when that blood sugar is low, or hyperglycemia, when that blood sugar is high? Hypoglycemia, that will kill a patient much, much faster. So you need to know the onset of the insulin to know by when that patient needs to eat. Look at this. The onset of this insulin is what? 15 minutes. And so they need to eat within 15 minutes of that injection, because we do not want that insulin to start working. What does insulin do? It lowers your blood sugar. We don't want that insulin to start working and lower that patient's blood sugar and they didn't have any food in their body. What do you think is going to happen now? That patient's going to bottom out on you. The rapid acting analogs most closely mimic natural insulin secretion in response to a meal. So just like when you eat a meal, your body naturally will shoot out more insulin. They do the same thing. That's what it's saying. You see, I put these stars. That means test question, know this. Let's take a look at this table, interprofessional care. So your diagnostic assessment. I'm not going to go through all of these, guys. I'm just going to go over the ones that are most important, but I don't write these exams, so make sure you know it. I'm just not going to go over all of them. All right. So blood tests, including your fasting blood glucose, postprandial blood glucose after patient eats, hemoglobin A1C, your fructosamine, lipid profile, BUN, serum creatinine, electrolytes, islet cell antibodies. All of those are diagnostic tests for diabetes. Fundoscopic examination, and in parentheses it says dilated eye examination. Remember, diabetes is the leading cause of blindness here in the United States. It doesn't matter how old that patient is. If that patient's a diabetic, they're at risk for losing their vision. So it's very important that at least annually they get their eyes checked. Foot examination, they need to go see the podiatrist, because patients who are diabetic, they suffer from what? Neuropathy, and we'll talk about that shortly, but it's very important for them to get their feet checked, and monitoring of weight, because in part 1, I talked about the importance of weight and the correlation with weight and diabetes, okay? Make sure you guys take a look at the rest of this table. Not that the rest of the stuff is important, but a lot of these tables and boxes and stuff I go over with you anyway, so I didn't bother going over the rest of them. So let's take a look at this, guys. Very important for you guys to know. You see, I said no, and I put 3 exclamation marks, so you know it's important. Your rapid acting, these are your rapids. This is your short acting, your intermittent, and your long acting. Make sure you guys know them. All right. So let's take a look at this. Rapid acting, your Lispro, your Aspart, your Glucosamine, okay? Onset, 10 to 30 minutes. That's when this insulin starts working. That's when it starts to lower the blood sugar. So that patient needs to have food in their body within that time. Whenever you get a test question about, when you would feed the patient, what they're really asking you, if insulin's involved, what they're really asking you is, what's the onset of that insulin? Because the onset tells you when to feed the patient. Peak. What is peak? Peak means high, right? So the peak of insulin is when that patient's blood sugar is what? The lowest. So when you get a test question asking you, the patient just got insulin, when is going to be the most dangerous time? When is the most high risk time? When is it most important, or when is a priority for you to reassess the patient? What they're really asking you is, what is the peak time of that insulin? Because the peak time of that insulin, when that insulin's working the best, is when their blood sugar will be what? The lowest. And remember, hypoglycemia will kill a patient a lot faster than hyperglycemia. Duration, 3 to 5 hours for rapid. When you get a test question asking you, you gave the insulin, when would you expect to give the next dose? What they're really asking you is, what's the duration of that insulin? So you would have to know the duration is 3 to 5 hours. So you would expect to give that next dose, what? 3 to 5 hours. When you know the peak time of the insulin, you know when you're going to reassess that patient, when you're going to know the most critical time for that patient, when they're in danger the most. The onset of insulin will tell you when that patient needs to be fed by. And that goes for your short acting, your intermediate, and your long acting. Okay. Something I want to bring to your attention for the long acting, look at the peak. Less defined or no. So if you look at your other insulins, look, peak is up here, which means the blood sugar is the lowest. Peak is up here, which means the blood sugar is the lowest. Peak is up here, which means the blood sugar is the lowest. But when it comes to long acting, it's steady throughout the day. Steady as, look, it lasts for 16 to 24 hours. There is no peak. You need to know that. Okay. All right, let's move on. And what's so interesting, guys, the same thing we're seeing here that I just talked to you, that I just explained to you, you're going to see it again in the text we're about to go over. What does that tell you? When the author writes something in the text, then they put it again, what is this? In a figure, and that same thing that they put in the figure, they gave to you in a table. What does that tell you? That tells you that it's important. It's most likely going to be a test question. These are going to be many test questions. I promise you that. So again, your short acting regular insulin has the onset of 30 to 60 minutes and is injected 30 to 45 minutes before the meal. We want to make sure that patient has food in their body before that insulin starts working. Why? Again, before a meal, to ensure that the onset of action coincides with meal absorption. I can't stress this enough. When it comes to insulin, the onset tells you when that patient needs to be fed. Short-acting insulin is also more likely to cause hypoglycemia. Look at this, because of a longer duration of action. Longer intermediate acting basal background insulin. In addition to mealtime insulin, people with type 1 diabetes use a longer intermediate acting basal background insulin to maintain blood glucose levels in between meals and overnight. Because remember, naturally, those who are not type 1 diabetics, their body naturally secretes insulin all day in tiny little amounts. Without 24-hour background insulin, so that insulin just being secreted in a little bit throughout the day. Without this, look at what it says, guys, people with type 1 diabetes are more prone to developing diabetic ketoacidosis. Your type 1s. The long-acting insulins, remember, long-acting has no peak, by the way. The long-acting insulins include, and it gives you the meds, we saw this already, this type of insulin is released steadily and continuously, and for many people, does not have a peak action. You must know this. Because they lack a peak action, the risk for hypoglycemia from this type of insulin is greatly reduced. Oh, here we are. Is greatly reduced. And it makes sense, guys, because when you have a peak of insulin, that's when the patient's most at risk for a hypoglycemic reaction. But the long-acting insulins don't have a peak, so they're less at risk for having that hypoglycemic reaction. It makes sense. Because they lack a peak action, the risk for hypoglycemia from this type of insulin is greatly reduced. Glargine and detamine must not be diluted or mixed with any other insulin or solution in the same syringe. That's something else that's important to know. These long-acting insulins, you don't mix them with anything else, okay? Intermediate acting insulin, NPH, is also used as basal insulin. It has a duration of 12 to 18 hours. Wonderful. But look at the disadvantage. The disadvantage of NPH is that it has a peak ranging 4 to 12 hours. What does that tell us? The NPH insulin, the peak of that insulin, 4 to 12 hours, is within given 4 to 12 hours of that insulin, that patient can what? Bottom out on you. So the time that you're going to be assessing them the most closely, you're keeping an eye on them. You don't want them to have a hypoglycemic reactions right here, 4 to 12 hours. Why? Because hypoglycemia will kill a patient much faster than hyperglycemia. NPH can be mixed with short and rapid insulins. NPH should never, ever, 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 ever be given IV. And I got star next to it, which means you better know it more than you have to know everything else. All right. NPH, Lispro, protamine, and asparprotamine are cloudy insulins because they contain protamine. By the way, guys, when you're drawing up your insulin, you know you draw clear to cloudy. This substance decreases solubility, and as a result, these insulins must be gently, not vigorously, gently agitated before administration. So what do they mean when they say gently agitated? Does that mean, pretend this is an NPH. Does that mean you go like this to agitate it? No, you don't shake it. What do? You roll it gently. And remember, you're drawing up your insulin clear first, then cloudy. All right, combination insulin therapy. For those who want to use only 1 or 2 injections a day, a short or rapid acting insulin is mixed with intermediate acting insulins, what? In the same syringe. This allows the patient to have both the mealtime and the basal coverage without having to administer 2 separate injections. This table, guys, tells us the same thing that the other table told us. Has a little bit more information, but basically the same thing. So insulin regimen. So look at your once a day single dose, your NPH at bedtime, or your long acting Lantus. Lantus starts with an L, long acting well, my L looks backwards for you. I guess it's this, but anyway, for me it's this, right? Your L long acting, no peak. Then you have your twice a day, 3 times a day, your basal bolus. I hate this. To me, it's too choppy. I don't like how it looks. So that's why I use the other table instead to teach out of this. But if this works for you, go at it. All right, let's talk about insulin storage. Insulin vials and insulin pens currently in use may be left at room temperature for up to 4 weeks, that's a month, unless the room temperature is higher than 86 degrees Fahrenheit or below freezing. But if it's like, normal room temperature, it can stay at outside of the refrigerator for up to 4 weeks. Prolonged exposure to direct sunlight should be what? Avoided. Why? Because that sunlight breaks down that insulin and will make it ineffective. A patient who's traveling in hot climates may store insulin in a thermos or a cooler to keep it cool. Look, guys, but not frozen. You can keep it cool just as if you had in the refrigerator, but not frozen. You want to store unopened insulin vials and insulin pens where? In the refrigerator. So think about it, guys. Once it's open, you can have it out, but it's unopened. Look, where do you need to have it? In the refrigerator. Pre-filled syringes containing 2 different insulins are stable for up to a week. So when you have those pens that have 2 types of insulins in it, you can use it for up to a week. When stored in the refrigerator, where syringes containing only 1 insulin are good for 30 days. That's important to know. You're going to teach patients to store syringes in a vertical position with the needle pointed up to avoid clumping of suspended insulin in the needle. So what does that mean? If this is a needle, you're going to have it standing up like that, instead of having the needle down like this, where all those particles can clump down at the bottom of the needle. That's why you want to have it stand up like that. That's what it's saying. Look at this. You're going to teach the patients to store syringes in a vertical position with needle pointed what? Up, to avoid clumping of suspended insulin in the needle. Before injection, you're going to, look at what this said, gently roll. Not shake vigorously, gently roll pre-filled syringes between the palms, just like this. Gently roll between the palms 10 to 20 times to warm the insulin and resuspend the particles. Because remember, they've been sitting like this the whole time. So those particles are going to be on the bottom, right? So you're going to gently roll them like this to help nicely, mix them back up. Administration of insulin. Routine doses of insulin are administered by sub-Q into the fat, not IM, not intra-arterially. How? Sub-Q. Regular insulin can be given IV when immediate onset of action is desired. So this patient is in a critical state and we need to get that blood sugar down immediately. We can give regular IV. Insulin is not taken orally. Think about it, guys. You have all of this hydrochloric acid in your stomach. You know what happened if you ingested the insulin? It would be deactivated by all of that acid in your stomach. So you can't take it orally. It has to be injected. Routinely, how's it injected? Subcutaneously. But if that patient's in a critical condition, you need to get that blood sugar down immediately. You can give it IV, but what kind of insulin can you give IV? Regular. That's important for you guys to know. Teach patients to avoid injecting insulin IM because rapid and unpredictable absorption can result in hypoglycemia. Again, what kills a patient faster, hyper or hypo? Hypo. We want to avoid hypo at all costs. So routine insulin we give how? Subcutaneously. If we're in a bind and we have to give IV, what are we going to give? Regular. We can give regular IV, but routine we're going to give subcutaneously. Insulin injection. Never, ever, ever assume that because the patient already uses insulin, he or she knows and practices the correct injection technique. So this is what you do. And this is for testing. You guys need to know this. Before you teach, you have everything you do, you always assess first, right? ADPI. So you got to find out how much you know. So you say, Mr. Such and Such, can you show me how you drop your insulin? You asking them to show you how to draw up that insulin, that's an assessment. Remember, guys, assessment is not only doing a physical head-to-toe examination on a patient. Anything that gives you information, anything that gives you insight is considered an assessment. Asking question, going through the patient's chart, that's an assessment, okay? So you say to them, can you show me or tell me how you do XYZ? And that's how you learn where you need to start your teaching, because they're going to do something crazy. And you're like, whoa, I need to start from point A to get to point B. Or you realize, okay, they know what they're talking about. I just need to brush up on some things. So it's important. Don't ever assume just because they've been a diabetic for years that they know what they're doing. The patient may not have understood prior instructions or changes in their eyesight, because remember, if you're diabetic, you're at high risk for losing your eyes. Or poor eyesight may result in inaccurate preparation. The patient may not see air bubbles in the syringe or may improperly read the scale on the syringe. The patient receiving insulin, mixed insulin in the same syringe needs to learn proper technique for combining them if commercially prepared pre-mixed insulins are not used. So for example, guys, remember I told you, you're going to draw clear to cloudy, but you're going to put that air bubble in what first? the cloudy. You're going to put the air bubble in cloudy first, then you're going to put the air bubble in the clear, draw from the clear, then draw from the cloudy. So it's very important to watch them to see if they even know how to draw up their insulin, especially when it's mixed. The fastest what? I don't know what they're talking about. Here we go. The fastest sub-Q absorption is from the abdomen. So what does that tell us? That patient getting the insulin sub-Q from the abdomen, they are at higher risk for that blood sugar going down than any other area sub-Q. The fastest rate of absorption is the abdomen, followed by the arm, thigh, and the buttock. Although the abdomen is often the preferred injection site, other sites also work as well. You need to caution the patient about injecting into a site that's to be exercised. Why? Because if they inject that site that they're about to exercise, guess what that's going to do? Increase the rate of absorption. What happens when the rate of absorption is increased? Blood sugar will go down faster. What kills a patient faster? Hypo or hyperglycemia? Hypoglycemia. So we got to be careful with that. So for example, injecting into the thigh and then going jogging could increase body heat and circulation, which could increase the rate of absorption and speed the onset of action, which can cause what? Hypoglycemia. Are you guys starting to see a running theme here? I hope so. Teach patients to rotate injection within and between sites. This allows for better insulin absorption. Let me stop here because I need to make sure you understand that. So for example, let's say the patient's injecting here, the subcutaneous site. Teach them, don't jump from here to here, to here, to here, to here. No, you're gonna rotate sites on the left, then rotate sites on the right, then rotate sites over here, then rotate sites over there, so you can keep track. That's what they mean when they say, teach them to rotate the injection within and between sites. This allows for better insulin absorption. It may be helpful to think of the abdomen as a checkerboard with each half-inch square representing an injection site. This is what they're talking about here, okay? Let's keep going. Injections are rotated systematically across the board, with each injection site at least half to 1 inch away from the previous site. So yes, guys, you're rotating sites, but within the same area. You're not jumping from one side to another. It could be helpful to inject fast-acting insulin into faster absorbing sites and slow-acting insulin into slower absorbing sites, which right here, they tell you which sites are fastest and which ones are slower. Most commercial insulin is available as U100, indicating 1 ml contains 100 units of insulin. So guys, by the way, the universal color for insulin is orange. That's why all of the insulin syringes have the orange cap. So that 1 insulin syringe, right, up to U100, that's 1 ml. You need to know that. Okay, last thing over here. No, I'm lying. I'm going to do a little bit more teaching before I end this video. We'll touch this in a second. Let's keep going. Needle gauges also vary among syringes. The needle gauges available are your 28, 29, 30, and your 31. Remember, guys, the higher the gauge, the smaller that hole that's in the needle at the tip of the needle, okay? The higher the gauge number, the smaller the hole diameter. That's what I meant to say. You guys know what I'm talking about. So the higher the gauge number, the smaller the diameter, thus resulting in a more comfortable injection. Only the person using the syringe should recap the needle. Why? You don't want to stick yourself. Only the person using the syringe should recap the needle. So you, as a nurse, can you ever recap a needle? Absolutely not. Never recap a needle used for a patient. The use of an alcohol swab on the site before self-injection is no longer recommended. So if the patient is injecting themselves, just like they can recap their own needle, that's fine. If they're injecting themselves, they don't have to use an alcohol swab. But if you're the one giving that injection, yes, you do. Routine hygiene, such as washing with soap and rinsing with water, is adequate. This applies primarily to what? Look at this, guys, to patient self-injection technique. So don't be confused. They can recap their needles. They can decide not to use an alcohol prep pad on themselves, but you, the nurse, you are never going to recap that needle, and you are going to use that alcohol prep pad. When injection occurs in a healthcare facility, that means you're the nurse, you're the one doing it. Policy may dictate site preparation with alcohol to prevent healthcare associated infections. Insulin injections are typically given, look at this, you need to know this, 90-degree angle. You're going straight in. Okay, 90-degree angle. Now, for extremely thin or muscular patients in the hospital, perform injections at a 45-degree angle. At home, patients inject at a 90-degree angle using the shortest needle desired. Pinching up the skin to avoid IM injections no longer necessary because of the availability of shorter needles. We used to have to pinch that skin so we can get the fat, but we don't have to do that anymore because needles are short. So once we inject, we're getting the fat. It's not like we're going deep into the muscle. An insulin pen is a compact portable device loaded with an insulin cartridge that serves the same function as a needle and syringe. And the insulin pen, guys, is good for the older patients who either their vision is decreased, or maybe younger patient who has decreased vision. And so with that pen, if they need 2 units, they can hear the click. They go 1, 2, and they know they're going to give 2. Or they can click 1 click, 2 click, 3 click, 4 clicks, and they know that's 4 units instead of visually trying to measure up that 4 units, right? Or, a patient that has problem drawing up the insulin with the pen, that insulin's already pre-filled. So if they have dexterity issues, they don't have to worry about drawing up the insulin. So for a lot of patients, a pen is a great option, okay? For patients with poor vision, the pen is a better option since they can hear the clicks of the pen as the dose is selected. Look at this, table 48-5, patient caregiver teaching. Very important, you're going to teach a patient to wash their hands. You're always going to inspect insulin bottle before using it. Make sure that it's a proper type and concentration. You're going to check the expiration date, make sure it hasn't passed. Insulin solutions, except for your intermediate acting insulins, should look at this, guys, clear and colorless. If it's discolored, throw it out. Something's wrong with it. It should be clear. For intermediate acting insulins, which are normally what? Cloudy, gently roll insulin between bottles. I can't speak, guys. Between palms, like this. So let me back up because I think I misspoke. I'm not sure if I did, but I just want to make sure I didn't. The insulin solutions, except for your intermediate. Your intermediates are the ones that are cloudy. So all your other insulins besides those should be clear. If it's not clear, you're going to throw it out. Now for the intermediates, those should be cloudy, okay? So I just want to make sure that I didn't misspeak. And again, guys, you're going to gently roll and not shake. You're going to select the proper injection site, make sure that the site is clean and dry. Push the needle straight into the skin. What angle are we using? 90-degree angle. You saw me put a star next to it. You need to know it. If the patient's very thin or very muscular, okay, or using an 8 to 12 millimeter needle, then you might have to pinch up the skin or use a 45-degree angle to make sure you get the fat. But otherwise, you're going to go into a 90-degree angle to administer that insulin. I'm stopping right here on insulin pump, guys. So that's going to be our part 3. And I have so much more to talk to you about. So I'm sure there's going to be a part 4 of this video. Please sound off in the comments. Let me know what you thought about this video. Let me know what you'd like to see more of. Don't forget, guys, on Sundays, 1 p.m. Eastern Standard Times, I go over questions, how to answer these questions, how to eliminate the wrong answer choices. But during the week, I'm going to try to continue to push out more lessons for you. So if there's something you'd like to see me cover, let me know and I will add it to my never-ending list. Don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com. If you want to practice questions with me on a daily basis, check me out. Facebook, Instagram, TikTok, I'm on there. Guys, thank you so much for watching this video, and you'll see me on the next video.